Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Swanson. Today's episode features content from an educational program titled Lessons from Lockdown, Evolving Models of Care for Liver Diseases. I'm delighted to introduce our expert faculty today. I'll start with Dr. Stacey Trooskin. She's the Chief Medical Officer at the Philadelphia Fight Community Health Center and on the faculty of the Perelman School of Medicine at the University of Pennsylvania here in the United States. We also have with us today Dr. Gregory Dore, who's head of the Viral Hepatitis Clinical Research Program at the Kirby Institute and Professor of Medicine at the University of New South Wales, both in Sydney, Australia. To link to the full program online, please visit the show notes for this episode. So let's get started and hear what Drs. Trooskin and Dore have to say about lessons learned in the management of viral hepatitis during the COVID-19 pandemic.
Hi there, I'm Dr. Stacey Trooskin, Philadelphia Fight Community Health Centers, and I'm here today with my friend and colleague, Greg Dore. Hi, Greg.
Hi, Stacey. Hi, everyone. Coming to you from Sydney, Australia, on a pretty chilly winter morning.
Excellent. Well, I'm glad that we're together today, and we're going to talk a little bit about how the COVID-19 pandemic has really impacted hepatitis C care in both of our countries.
Yeah, it'd be great to share, I think, our experiences. There's some things that are very similar across the settings, but there's some things that are very much contrasting, and I think we can learn from each other.
I couldn't agree more. Well, the Centers for Disease Control and Prevention in the United States have tried to provide some guidance around what people with chronic liver disease can do in the COVID-19 pandemic. And among those things are encouraging people to take medication as prescribed, to remain engaged in care, make sure that you have ample supply of prescriptions at home, and to make sure you're being vaccinated for other diseases. And then to leverage telemedicine or other engagement in care with your primary care provider as well. Are things looking similar in Australia?
Yeah, I mean, we've been somewhat less affected by the COVID-19 pandemic. During 2020, for example, in Sydney, we had long stretches where we had no cases at all. So in fact, our sort of interactions with patients for many months were pretty normal. We're now in lockdown in Sydney, so things are maybe similar to how you were for much of last year. So we've had a later sort of impact, but we've had to adapt, as I'm sure you've had to adapt in terms of patient-clinician interactions.
Indeed. I think very early on in the pandemic, we needed to shift, which I think was difficult for some of smaller organizations like ours, community health centers, federally qualified health centers. Telemedicine was not a regular part of what we offered to patients. It was difficult to get reimbursed, and it wasn't part of the offerings that we had in medical care in the United States. And so many of us had to pivot very quickly and launch telemedicine in order to stay connected with our patients when we very quickly went into lockdown. And so we did this, and our patients adapted beautifully, as did, I think, many healthcare settings very quickly and urgently. I think early on, we wrestled with the digital divide. And what I mean when I say that is that there are some of our patients who do not have regular access to computers or smartphones with cameras. So those patients, it was more difficult to engage in a video visit, and we were relegated to just a regular telephone visit. And I think particularly when we went for long stretches, it helps to actually see your patient and be able to connect with them that way.
It's interesting, in Australia, we had a telehealth item already. So in Australia has a universal healthcare system, and within the context of that, we had telehealth billing capacity. And that's probably because we often have patients in the regional rural areas, so it's used for that. So when the COVID-19 pandemic sort of hit, very quickly they expanded that telehealth sort of billing capacity. So there's never been an issue in terms of getting sort of reimbursement for telehealth. A lot of clinical services have had to get up to speed, and there's various ways that people have approached this. And some clinics are doing video sort of link mostly. Other clinics are using the phone. I think it's just a bit of a mixed bag. But there's no doubt that like you've had to do, we've had to adapt.
Yeah, I think now that we're sort of a year and some change into the pandemic, some of the emergency legislation and relaxed restrictions around telemedicine, around some privacy and HIPAA rules that we have in the US, they're being reinstated. And so there's a big question now as to what is going to happen with telemedicine moving forward. Will it continue to be reimbursed by our payers? Is it something that agencies are going to be able to do in larger healthcare organizations? And it remains in limbo right now. And I think that, there's there really is no substitute for laying hands on patients, but certainly when you're unable to do that for whatever reason, it's nice to have it as an option, as a supplement to stay connected to patients. And I think that now that we've seen the path forward with telemedicine, it's going to be hard for us to go back completely and not have it as part of our offerings should it come to that. So I know many of us are hopeful that we'll continue to be able to integrate it into our offerings to patients and still be reimbursed for it, which is what will make it sustainable for so many of our practices.
I think the sustainability, there's no issue with that in Australia. I think it's very much going to be built into the overall universal healthcare system. I would love to get to the other side, so to speak, and be able to have patients come to the clinic and to have face-to-face contact. I think particularly for marginalised people who inject drugs or experiencing homelessness, that sort of trust that you build up as a doctor is really crucial. And I think that trust is more easily developed in close proximity. Understand the limitations and constraints we have to work with at the moment, but I really do hope we get through this and back to some sort of similar approach that we had before.
Yeah, as do I. I know for us, working in a federally qualified health center, we're able to provide sort of one-stop shopping for our patients. They can come in. We often will be able to get them a snack or a hot meal, some clean socks, visit with a case manager, or even our behavioral health consultant when they come in, and all of that gets interrupted. We can certainly refer to those entities and make sure our colleagues follow up with them, but it ends up being a whole separate telephone call or a separate video visit, and it doesn't have that same warm handoff and feeling for the patient when they leave, that they've sat with somebody, they've spent time, and they've gotten more than just their physical health needs met. So I agree. I'm looking forward to the time where we can offer that without any hesitation whatsoever. Yeah. So for you in Australia, Greg, what are some of the ways that you've been able to overcome some of the digital literacy barriers and health system barriers? I know that having a universal healthcare system makes it a lot easier with respect to sustainability, but for those marginalized patients that may not have access to housing or a telephone, how are you able to mitigate some of those challenges?
Well, it's interesting. I think the response to the COVID-19 sort of pandemic, particularly in Sydney, has been very good in terms of those people, for example, experiencing homelessness. So there's been special accommodation that's been developed for them. So many of them have been housed actually through the last sort of year or so in specific accommodation. There's also been really encouraging initiatives to get people experiencing homelessness vaccinated, so they've been a priority population. So that sort of interface, I think, with our marginalised populations certainly hasn't fallen down. I think we've responded relatively well. On the sort of Hep C clinical side, it has been difficult. There's no doubt about that. I think but the community-based services in particular have sort of kept things going reasonably well. We haven't seen the increase in drug overdoses that you may have seen in the United States. We don't think there's been a big change in risk behaviour. We're certainly not seeing any evidence of increase in incidence of hepatitis C. In fact, our incidence looks like it's continued to decline. because we have less active infection around. So I've been pretty encouraged by how things have panned out during the pandemic.
That's amazing. One of the areas that I think we've been most successful in engaging patients that we've had trouble reaching pre-pandemic have been folks who are unstably housed, actively using, don't have a way to get in touch with folks because their phones have either been lost or stolen, or they've run out of minutes or what have you. And so one of our really successful telehealth programs has allowed us to embed a tablet in an inpatient drug treatment program. And they've done a beautiful job of routinizing hepatitis C testing. And we have somebody that is from our health center that will go out there and facilitate these visits and draw the necessary blood work and so on. And so we've been able to engage patients that way while they're in a 30, 60, 90-day stay for drug treatment and virtually get them treated while they're there. And that's been really rewarding to be able to do that. And the telemedicine piece has really allowed that for the first time for us to meet people where they are. And then when folks are released, they're coming in to see us for primary care and to meet us in person. So that's been great. That's been really great. I think one of the challenges that we've seen in the US for the folks that have made it into these drug treatment programs, it's been great, but there has been a real stifling of our community-based programs in the US. Our syringe service programs, albeit limited in number that they are, haven't been able to operate safely, particularly early in the pandemic. I think we've all learned to adapt in this new normal that we're in now, although now with the Delta variant reemerging or emerging and becoming more of a concern, we're sort of reassessing our previous operations. But for the greater part of the year, we've been able to operate in this new normal. But for a large number of these community-based organizations and harm reduction services that we've had, they haven't been able to operate normally or at the same capacity with social distancing rules. And I think part of that is to blame for this huge increase that we've seen in the US in our drug overdose deaths. We've had a 29% increase in drug overdose deaths in the year ending September 2020. And the upward trend began slightly before the pandemic, but the biggest jump did occur from April to May in 2020, which is really early on when nobody was operating. We were totally shut down, and it just really highlights how life-saving these harm reduction services really are in the US. And just sort of echoing what you shared with me earlier is that you haven't seen an increase in overdose deaths in Australia the way that we have. It makes me concerned for, as new variants emerge, if we're unprepared or slow to respond, what we may see again, because people need those services.
I completely agree. I mean, we've been fortunate, I think, that because our harm reduction services are so well embedded, and there's general support, particularly government, but also at the community sort of level, that it hasn't been an issue in terms of access. So they're considered essential services. So there's no way that they would be limited or closed down due to lockdown sort of requirements. So they've been operating as normal. With the usual sort of social distancing and masking sort of requirements. There's also been an increase in the use of depot buprenorphine across the country. That's sort of come in as a major sort of choice in terms of opioid agonist therapy. So it provides a bit more flexibility for those people who can take a longer acting sort of slow release form. It's great they don't have to come in on a regular basis for their therapy. So that's been good. So yeah, we haven't had I don't think it's been a major sort of concern in terms of the overall harm reduction. And it certainly, as I said, hasn't been reflected in terms of increased overdose or increased incidence of Hep C. We have very little HIV amongst people injected in Australia. So we're not seeing any uptick at all in bloodborne viruses.
That's great. I think, certainly the way that our governments view harm reduction services differs greatly, but also the rollout, generally speaking, of Hep C treatment has been very different in our two countries. And I know that the government investment that you've seen in Australia has really enabled an extraordinary number of people to be treated.
Yeah, it's amazing. So since March 2016, when we had government-funded direct-acting antiviral therapy, we've treated almost 100,000 people. And I think one of the keys has been from sort of day one of that program, there was no restrictions based on drug and alcohol use, no restrictions based on liver disease stage, and importantly, no restrictions based on prescriber type. So anyone who's a registered practitioner in Australia could write a script, initially with some support from specialists for the inexperienced practitioners. We also now have nurse practitioners that are prescribing. So that sort of breadth, I think, has been really crucial because we've been able to roll out treatment in drug treatment services and now needle and syringe programs and community clinics, which has enabled us, in fact, to have a remarkably higher uptake among people who are currently injecting than the broader Hep C population. And even though there's been some decline in the numbers of people being treated every year, we can see a sort of population level impact. So we do a survey where we recruit around 2,000 or 2,500 people every year. We do a behavioural survey asking about Hep C treatment as well. And we do a dry blood spot sample to test for Hep C RNA, so for active Hep C infection. And more than 60% now being treated for Hep C. And you can see that the proportion of active infections declined from over half prior to the rollout of the program to just 16% in the last survey period, which was October last year. Still a bit of work to do, but a pretty impressive evidence of the population level impact. And we're very proud of the program that we've been able to put in place.
It's inspiring for the rest of us, for sure. Aspirational.
One of the other things that we've been able to do is talk a little bit about sort of innovative programs. And I think the big push now that we're seeing some declining numbers of treatment, and we really want to do two things. One, see that we can simplify the pre-treatment assessment and support people through a diverse range of outlets. We did a study called Tempo, sort of pilot study, was in one needle and syringe program, and we wanted to get all the assessment down to a finger prick. So in fact, people had finger prick assessment for Hep C RNA with a point of care machine platform that gives you the result within 60 minutes. They had a finger prick serology for HIV and also for hepatitis B. We had a portable fibre scan that we used. So people that had cirrhosis need further sort of clinical workup. But the vast majority who had pre-cirrhosis, that was it, no safety bloods. These therapies are so well tolerated, so no safety bloods, just everything through finger prick. And then we tried to initiate people as quickly as possible. In fact, around half the people initiated that same day. Several more initiated the next day. So we're able to get the large majority of people to start therapy within 1 day of that initial assessment. And another key aspect of the pilot program was we had peer support workers. So they met the clients at that initial assessment. The nurse was doing the main sort of assessment, but they were linked in with a peer. The peer would then be in contact with them at least once a week, and generally by phone, sometimes in a face-to-face meeting up, and help support them through that program, either an 8-week program or 12-week program of treatment. So just an example of, I think, how we can simplify things and how we can modify our sort of assessment and treatment delivery to the requirements of marginalised populations.
I mean, I think a test and treat model certainly is the holy grail here. We shouldn't be overcomplicating things when it can be so straightforward. So that is really encouraging to see. I know that the MINMON study really sort of brought home the ease with which we can use the simplified model and the efficacy of that for treatment. And, the MINMON study was this phase 4 open label multi-country trial, which evaluated the efficacy and safety of this minimal monitoring approach. And the N was 400 patients, and they used Sofvel for 12 weeks and included a diverse population. Those with previously untreated Hep C, compensated cirrhotics were included, as well as those with HIV co-infection. They did, however, exclude those with chronic Hep B, decompensated cirrhosis, and pregnancy. And the simplified approach here really was no pretreatment genotyping, because we're using a pan-genotypic regimen. There were no scheduled on-treatment visits, labs, and they got all 84 tablets dispensed up front, which, at least in the US healthcare system, is a tough thing to do. You got to get your monthly refills. And that was the model. And it did show that 95% achieved SVR, including 95% with co-infection with HIV. And just among those 20 who were non-responders, 17 had a detectable HCV RNA, 2 were lost to follow-up, and 1 had a sample outside the study period. So, I think it gives us this lesson of the value of a simplified treatment approach. We certainly had to embrace some of this in the pandemic, and it gave us some confidence that we were able to move more toward this minimal monitoring approach with our patients when we couldn't lay hands on them, bring them into clinic, and engage them in the way that we were used to doing. But I know that you and I, Greg, agree that there are some patients that may benefit from more frequent touches if they have like unstable housing or other social determinants that may require support in other ways. What are your thoughts?
Yeah, I think minimal monitoring doesn't mean minimal contact. Yeah. So I think the Tempo study demonstrated that. So we can have few assessments, we can simplify the assessment sort of part of things, but we can keep in contact with people, and that's where the peer support was really crucial. So if they ring clients once a week, that's definitely not minimal contact. That's really crucial contact, but they don't need to have assessment on treatment if they're taking the medications, and they just need that support, I think. And so we can sort of marry those together in a way, the MINMON with that sort of overlay, I think, based support for the more marginalised populations. And I think it's a really nice sort of mix, and it's how we should be doing things going forward for people who are marginalised. Absolutely.
Yeah, I totally agree. And it's nice to think about doing that with a multidisciplinary approach. It doesn't need to necessarily be a televisit. It doesn't need to be an in-person visit. It can be a call from a peer or a pharmacist or a nurse, just to check in and make sure that things are going okay, and to make sure that the patient has no needs that maybe have the potential to impede adherence or compromise that.
The thing that I've been really amazed by, and maybe I shouldn't have been amazed, but is how motivated clients are to be cured. And some of them need clearly more support than others, but most people just want to get this therapy, get cured of Hep C, and it's a really positive aspect to their overall medical care and their sort of quality of life. They can deal with hepatitis C relatively easy if we put some pretty simple supports in place, I think. Absolutely. I couldn't agree more. Well, thanks for spending some time and chatting with me this afternoon. An absolute pleasure, Stacey. Hopefully we'll get to meet face-to-face soon. I hope so. All the best.
Well, thank you so very much to Dr. Trooskin and to Dr. Dore for that engaging discussion. And thanks to our listeners for joining in. As a reminder, to view the full educational program online, Lessons from Lockdown, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.